This is Addiction Medicine Journal Club. I'm Dr. Sonia Daltredici.
And I'm Dr. John Keaton.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. Remember, this podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, I'm pretty excited because we're going to be discussing the first randomized controlled trial of semaglutide for alcohol use disorder. How are you doing this afternoon, John?
I'm doing great. Just enjoying this change in the weather, the nice kind of fall spring here in southern PA. How about you?
I'm doing great. It will snow at least one more time, I'm sure, before it's all over, but I'm having a great day.
Yeah, I remember when I moved here, someone's like, "Oh, the onion snow in the end of April, early May." I'm like, "What the heck is onion snow?" And I guess it's a common thing here. So I guess it's the first crop you can plant. It's kind of cold resistant.
Yeah, there you go. So, John, anything you want to share about addiction in the news this week with our listeners?
This isn't kind of so much in the news, but I thought this is kind of worthwhile sharing. And I'm going to kind of apologize. I'm going to use a brand name here for a product, but actually kind of the other week in our office, Depot buprenorphine Sublocade is the brand name I'm referring to. The rep was actually in our office, and I thought it was interesting that there's been some kind of changes in terms of kind of its approval and how it can be administered. Actually, kind of three relatively big changes. One is the sites have been updated, so it's no longer just the abdomen, but also you can do the kind of arms, thighs, buttocks, which kind of opens up some targets for you, especially if you're injecting into a relatively small or lean patient. I thought it was interesting too. They've dropped now. You don't necessarily have to do the 1 week oral lead in. And then also you can do the second loading dose a week after the first loading dose. So kind of all ways to kind of accelerate initiation of the product. So actually that's kind of been a big change for me. And I think that's going to be really useful going forward for a subset of patients that have kind of a difficulty with initiation or just have 0.1% body fat. And I'm injecting into nothing.
No, I think those are awesome changes. Actually, I've been looking at that too. I did try this week to order the 1 week, the second loading dose 7 days after the first one. It was denied by the patient's insurance. They said it was too soon. And my helpful submission of the new prescribing guidelines did not convince them otherwise. But, hopefully they'll catch up.
Yeah, it's always hard because FDA approval precedes kind of like insurance approval in almost all cases, right? And when we see that for a lot of other conditions, it's kind of unfortunate.
I mean, I'm really excited about the dropping of the 7-day lead time because, for those of you who don't know, the long-acting injectable buprenorphine, this brand, Sublocade, you're supposed to be on oral buprenorphine or sublingual buprenorphine for 7 days prior to your first shot. And they dropped that down to a single dose to make sure you tolerate it okay?
For the loading dose?
Yeah.
Yeah.
Yeah, so, now you could give it it opens up to give it, in the ER or in an emergency setting or, a mobile clinic. You could get a single dose and then a few hours later get your first injection, and I think, honestly, in practice, a lot of people have been doing that already, but it's nice to have it be officially sanctioned.
Yeah. Especially just the cost, right? I feel like the fact that coverage is going to eventually kind of relate would be really useful.
Yeah, no, agreed. I think that's a huge update.
How about you? Anything kind of in the news for you?
Again, not really news, just like yours, but definitely another update. I don't know if anyone's seen it, but ASAM just put out guidelines about benzodiazepine tapering, and I'll put a link to their guideline. And they also have a bunch of free webinars in the show notes. But it's about dealing with people who have benzodiazepine use disorder and what to do with the benzodiazepine taper. And, benzodiazepines are a huge problem for us, and there's a real paucity of evidence in this area. And, the writers of this guideline really admit that most of the information they put is expert opinion. And they did a lit review, as you would do for any major guideline, and they identified only 57 articles to put in this major guideline, which I think is kind of a crime because this is a medication class that's widely used and causes a lot of damage. And there's very few high quality trials to guide our use. So that was the first thing I noticed. And then a few things stood out to me in the guidelines. They acknowledge that it can take months to years to fully taper off benzodiazepines, especially if patients have been taking a high dose for an extended period of time. And they say that many healthcare systems may not be able to manage the volume of patients who would benefit from benzodiazepine tapering, which is a big acknowledgement. And so they recommend that we triage patients, prioritizing those at the highest risk of harm from benzodiazepines. So just sort of admitting that it's a little overwhelming to try to get people off their benzodiazepines given the large number that we prescribe. There was a lot of nice charts, like with some sample tapering schedules, some benzodiazepine dose equivalents if you're switching from a short acting to a long acting, and even some sample case studies you could run through. But the thing that was most interesting, like, I feel like it's not too complicated. If a patient wants to come off benzos and you want to do a long taper and you taper by, 10% per month and everybody's in agreement, like, that's not really a hard problem. They come in once a month, they get a new script every month, it's slightly less. It's all great. But the thing that's really hard is when the patient doesn't agree with the benzo taper. And this guideline contained an explicit section on working with patients who are not in agreement with a taper. And that's really been my dilemma because, some of these guidelines regarding opioids and opioid tapering assume that if you have a careful discussion with the patient, you talk about the risks and the benefits, the doctor and the patient will always agree on what the course of action is. There'll be mutual agreement and you'll move forward
Hmm.
once everybody understands the risks and benefits. And I don't feel that I've always found that. Um,
No,
so
not like never.
right. And
No,
so
that's not true. Not it's the answer is never, never. But I
right.
mean, it's a large percentage of cases. It's a problem, right?
Well, right. And that's the real elephant in the room with primary care and, controlled substances. Like with addiction treatment, usually we're on the same page as our patients. We all know that the drugs are a problem and we all know that we want to get off them and everybody's working towards the same goal. But when you're doing like chronic controlled substance prescribing and you as the doctor feel the risks outweigh the benefits and the patient disagrees, and I think sometimes they disagree because of their dependence, not because of other benefit they're getting from it. It's kind of like, what do you do? And that's not really addressed in a lot of other guidelines. So I really appreciated they address that. And they also address specifically what to do with inherited patients. If you come in as a new doctor and suddenly patients walk into your office already on these medications and ask you to continue them, and not continuing them puts them at risk for horrible withdrawal, but continuing them against sort of standard practice guidelines puts you at risk for unsafe prescribing, and if harm comes to the patient, you would be culpable. And so I just really appreciate that they addressed both of those issues. So, John, do you do, like, benzodiazepine tapers for people at a long term?
I've done a fair number of them in the past. I mean, it's really hard. You're right. I think most patients don't feel that they want to kind of come off these medications, but there's times where it's just not safe. Like older patients falling with hip fractures that continue to fall. That's a very strong association. And then there's people all the time that are not using them kind of appropriately, right? And that's really hard because I believe their anxiety is there, but I don't know if them running through 120 alprazolam in 12 days is really that's really I'm helping them. And it's hard, just like opioids, right? There's really like a paucity of data for safety of these and efficacy for long-term use, right? There's tons of data for benzodiazepines as like a bridge to another treatment course, like up to 30 days. But in terms of like these long-term benzodiazepine scripts, I have not seen a bunch of data that this is like, recommended. In fact, I've seen some data that paradoxically it worsens anxiety and panic disorder in the long term. So it's hard.
It is hard, and there's also data, unfortunately, like there is with opioids, showing that patients who are on long-term high dose or any benzos, long-term benzos, they have higher risk of turning to illicit drugs and higher risk of suicide and suicidal ideation if they're taken off their long-term benzos. So it's kind of like we create the problem iatrogenically as doctors, and then we cause more problems by taking people off it too fast. The patients are the ones who kind of lose out in the end.
Yeah, it's hard. I feel like most of us, like most of my patients have inherited, and it's like, they've been on them for 20 years from their previous doctor. They never even knew there was a harm with it. Like they
Yeah.
didn't realize there's any problem with being on these, like taking them all day, every day. And it's hard because, and there's also like some data that some medications are not effective after you've been on a benzodiazepine chronically. Like I think Buspar is a one that there's data that, once someone's been exposed to benzodiazepines, that's not an effective treatment option.
And I've heard that anecdotally from patients and, other people I know who've been on high dose benzos, especially short acting ones like alprazolam, which is Xanax. People say colloquially, once you've been on Xanax, nothing else will work for you. It kind of, quote unquote, ruins all the other meds for your anxiety.
Once you've driven the Benz, you can't ride the bus.
Oh my gosh. On that note, John, you want to tell us about this article?
Yeah, so I'm like really excited about this article because I think going back now like 2 years, people have been like nonstop talking about semaglutide for alcohol use disorder and addiction. And I think at ASAM, the one year there was a lot of poster presentations about a lot of anecdotal evidence. Interestingly, I'm on a Facebook group called Physician Community. It's like 10,000 docs, and a lot of times posts come about people that have noticed that as they've been on their semaglutide, they're not drinking as much. So a lot of anecdotal stuff. And then there's been a lot of like these kind of like population level studies about kind of like an association, but I haven't seen any RCT data. And so I was really excited when this came out in JAMA last month of February 2025 that, we actually now have a trial about this because I think this is something we've all been waiting for. Spoiler alert, it's a phase 2 trial, so it's not there's going to be some caveats with that, but it's at least some true RCT data. The article is called Once Weekly Semaglutide in Adults with Alcohol Use Disorder, a Randomized Clinical Trial. It's from JAMA Psychiatry of February 2025. A little bit of background about this. Alcohol use is a major cause of global morbidity and mortality. It has a 4 to 5% disease burden with 2.6 million deaths annually globally. Alcohol is linked with 200 plus conditions, including heart disease and liver disease. But actually, we're increasingly recognizing the carcinogen risk of this and how it's highly associated with a lot of other cancers like breast cancer. Alcohol-related liver disease has increased since 2020, contributing to a 29% rise in U.S. alcohol-related mortality. 178,000 alcohol attributable deaths occur in the US every year. And that's kind of directly attributable. I think that's not even counting in the fact that like we're increasingly recognizing it as a carcinogen involved with other disease conditions. I thought this was kind of staggering. 29% of US adults meet lifetime alcohol use disorder criteria, with 11% of US adults meeting criteria in just the past year. So pretty high. And it's actually very age-based. I'm not sure if you've seen the data about this, but kind of, I feel old saying this, but the younger generation, I always kind of get confused by the different ones, but the latest generation of kind of healthy eating, work-life balance group is actually drinking less than kind of older adults, which I think is interesting.
Right, but they're balancing it out by using more cannabis, so we'll see how they turn out in the end.
Fair enough.
Sorry, that was a little negative. Sorry, young people.
I, I'm still optimistic about their approach to life in general, right? I like the fact that like how they look at life a little bit better. I would say that there's some critiques that could be made, but I do like the fact of people valuing work-life balance and health is kind of a nice change.
Yes,
Um,
it's probably better.
it is better. Less than 10% of patients with alcohol use disorder receive treatment, and less than 2% ever receive pharmacotherapy for that. So a very small subgroup actually gets treatment with pharmacotherapy. I didn't include this as a bullet point, but very staggering information was like, if you look at like our current rate of FDA approved drugs for alcohol use disorder dating back to the 1950s, we get like a new drug every like 25 years for this. So it's really not a very, for something that's so common, affects health so much, we really don't have a bunch of options and we don't have a bunch of development of new options. There's a treatment gap for alcohol use disorder due to the limited FDA approved therapies, stigma, and lack of awareness. A growing number of studies shows that reducing alcohol intake improves health globally, both kind of physical health and mental health. GLP-1 receptor agonists are FDA approved for diabetes and obesity. Actually, there's newer indications as well for coronary artery disease, obstructive sleep apnea, although I haven't seen an insurer cover them for that, but they do have those indications now. And they're really kind of quite a large uptake. I think the last I saw, I think it was 6% of the US population is on a GLP-1 agonist with like a lifetime prevalence of like 14%. Don't quote me on those numbers, but it's a relatively high percentage of people. And I would tell you, for every person on it, I have 2 patients in my office asking me to prescribe it that their insurance doesn't cover, if I would just say on average. The GLP-1 receptor agonist semaglutide has been shown to reduce alcohol in some preclinical trials, also some animal model trials. And off-label use of GLP-1 receptor agonists um, uh, semaglutide for alcohol use disorder has subsequently been reported, but clinical evidence for these practices is limited. So, kind of very interesting. The clinical question in this trial is, does the GLP-1 receptor agonist semaglutide reduce alcohol consumption and cravings in adults with alcohol use disorder? So, a little about this study. So, this is a phase 2 double blind, randomized, parallel arm trial conducted to evaluate the effects of once weekly semaglutide on alcohol consumption and craving in adults with alcohol use disorder. The study involved 9 weeks of outpatient treatment with enrollment occurring in an academic medical center between September 2022 and February 2024. The study was a hybrid design combining outpatient and laboratory components to assess primary and secondary outcomes of alcohol consumption and cravings. Just to give you an idea, so we don't often evaluate or discuss like phase 2 trials here, but if you remember back from basic science, there's 4 phases to medical research. Phase 1 is a very small number and mostly looking for safety. Phase 2 is still a very small population. This is where you're actually starting to look at efficacy of treatment. Phase 3 is the last phase prior to dissemination of the product to the general population. That's a very large study looking at kind of treatment effect on a larger population, also assessing adverse effect. And then the last phase of the FDA approval process is phase 4, and that's basically post-marketing research where a product is in the environment and we're continuing to collect data on it. And ironically, phase 4 is historically where most drugs are recalled that do have a problem. So
Well,
this
and
is
this
phase
is
2.
and, often we don't present phase 2 because a phase 2 drug isn't really available to the general public yet, but this is a widely available drug, and so
Mhm.
even a tiny bit of data in this direction will, because as you know, like, doctors can prescribe meds really for anything. The FDA approval doesn't determine what you can prescribe it for, so, this is a phase 2 trial, but it's a widely available drug already, so even this kind of preliminary data, I think, will drive prescribing even if it doesn't drive insurance coverage.
Yeah. So participants enrollment here, there's 504 potential participants were screened for enrollment with 48 actually selected and randomized. So like a little less than 10% were, or a little bit more than 10% were actually selected. It was 48 non-treatment seeking adults with alcohol use disorder. And what does it mean by non-treatment seeking? It means that they weren't actively looking for drug and alcohol counseling. They weren't kind of engaged in an abstinence program. They weren't coming to a physician specifically for alcohol use disorder. So these were people with you might say like from a lay term problematic drinking that weren't specifically seeking treatment, but met criteria for alcohol use disorder. The inclusion criteria was adults aged 21 to 65. They met DSM-5 criteria for alcohol use disorder in the past year. You had to drink more than 7 drinks per week as a woman or 14 drinks per week as a man with greater than or equal to 2 heavy drinking episodes the past month. Exclusion criteria was actively seeking treatment for alcohol use disorder, use of a GLP-1 receptor agonist or weight loss medications, a BMI of less than 23, history of diabetes, or another medical condition that would preclude the use of a GLP-1 agonist. A little bit about the protocol. So I really like how they kind of did this. I thought it was kind of interesting. So week 1, they basically did a pre-treatment alcohol self-administration session. You're like, what is that? And basically, that's a session where patients you find out what your preferred beverage of choice was that had alcohol in it. They presented you with it. They first just basically left the alcoholic beverage out and they gave you the option to delay drinking for up to 50 minutes for monetary reinforcement. So could you just kind of have the drink in your presence and you not drink for that first 50 minutes? They were then instructed to drink at their preferred pace to receive their desired effect over the next 120 minutes. And then alcohol consumption was measured in kind of grams of alcohol consumed, but also breath alcohol concentration every 30 minutes. So they kind of had a combination of like, first of all, can you resist drinking during the first hour? How much will you drink when you're allowed to drink at your own pace and to your own desired effect? And then kind of measuring how much alcohol was accumulating in your system during that period of time.
It's like that grown-up version of the study with the kids and the marshmallows. I don't remember what that was called, but the study of delayed gratification.
Yeah, I remember that one you're talking about. It was in like a movie too. Yeah, and so the question came up at our live journal club, like, is this like a kind of a standard of care validation for alcohol use disorder? And It's interesting. I did some brief literature search about this, and this is not totally novel, although there's not like a standardized approach, but like a self-administration assay to see whether you kind of drink, resist, and how much you drink is something that has been done before in many other trials dating back to, I think the earliest I saw was like the early 2000s, probably some or even before that. Some were even computer assisted, where like you could, answer to a computer prompt to receive alcohol. But basically, a self administration session is a relatively validated outcome for many kind of drinking related studies. Also, during that first week, you would get your first dose of semaglutide, which is 0.25 milligrams, or you got a placebo. For weeks 2 through 4, you got your weekly semaglutide at the 0.25 milligram dose, and you got outpatient assessment of alcohol consumption and cravings. This is more subjective data. As a reminder, for the GLP-1 agonists, typically dose adjustments are allowed every month. So every 4 weeks, you can do a dose adjustment up. From weeks 5 to 8, semaglutide was increased to 0.5 milligrams weekly, and they continued kind of outpatient assessments of alcohol consumption and craving. Weeks 8 to 9, they repeated that alcohol administration assessments. So they brought you back, let you drink over that period of time, saw how much you consumed. And then they got the final dose of the semaglutide where they were raised to 1 milligram, so kind of the max. And then week 10, they did a discharge visit where they obtained more subjective data and they did a final assessment. So that was kind of the treatment trial. For those that aren't like aware of these medications, maybe like you're either in behavioral health or you're kind of more a lay person, that's not a relatively high dose of semaglutide. So like the treatment range for diabetes starts at 0.25, goes up to 2 milligrams. Interestingly, the treatment dose for weight loss is even higher, up to 2.4 milligrams. So you're kind of at like a 40% max dose based upon kind of other trials and conditions.
Yeah, that was a little surprising to me because with obesity, you get better effect at the higher doses, and you'd think they would have shown more positive effect if they'd managed to go up to the higher doses. I don't know if it had to do with like not wanting to continue the trial longer, it being sort of a phase 2 trial, kind of more proof of concept. And they're going to do a phase 3 trial next that'll take them all the way up to the max dose. But yeah, no, I agree that 1 milligram dose isn't always effective for some of the other indications. So.
The primary outcome we talked about is laboratory alcohol self-administration, kind of looking at alcohol consumption in grams of alcohol consumed and peak breath alcohol concentration as a surrogate marker of blood alcohol concentration. Secondary outcomes were weekly alcohol consumption, so how many drinks per day and how many days per week were people drinking, heavy drinking days, alcohol cravings. They also looked at cigarettes per day in the subgroup that smoked, and they had like an exploratory outcome for smoking. Statistical analysis, they did this linear mixed models of the primary and secondary outcomes used in intention to treat to determine kind of what the likelihood of the association was between alcohol consumption and use of the product. A little bit of this about this trial. So, is it valid? So, funding was by the National Institute on Alcohol Abuse and Alcoholism, National Center for Advancing Translational Sciences, UNC Chapel Hill Department of Psychiatry, and Bowles Center for Alcohol Studies. There was authors reporting some conflicts of interest with industry. Novo Nordisk was one. Another one was Eli Lilly. So a little bit of conflict, although it doesn't sound like that was directly funding the trial. I think the biggest thing to kind of keep in mind here before you could, if you use this with your glasses, viewing this like a phase 3 trial, like most of the time when we use the term RCT or randomized control trial, and we're talking about a trial, we're talking about a phase 3 trial. So this is phase 2. So I think you have to give it a little bit of grace for some of the typical critiques we give to other trials. So it's a very small study looking for positive outcomes, paving the way for a larger phase 3 trial. So it's kind of a bridge to an endpoint. It's not the end of the study here. It's a very small, double-blind, randomized, parallel-arm trial, and so there's 48 non-treatment seeking participants. There was some critique about that. They're non-treatment seeking. I would argue that the majority of patients with alcohol use disorder that meet that criteria are not specifically looking for drug and alcohol treatment. Oftentimes, people are looking to mitigate alcohol use but still drink, and that's kind of the average person. I do question whether it's truly possible to blind someone with a GLP-1 agonist. Having prescribed a ton of these, the side effect profile is very pronounced and very predictable. I have a neighbor down the road that I prescribe it to, and he just says he lost weight. I go, "You look great," and he's like, "I just feel like crap all the time. I just want to throw up all the time." It's like, "I'm glad I look great to you." I'm like, "Well, do you not want the medication?" He's like, Yeah, give it to me still, please." So it's kind of funny. Like people like the effects, but no one likes being on these from what I've determined or what I've seen in clinical practice.
Right, I mean, sometimes you see in the studies they report like, they do a survey afterwards, "Do you think you got placebo or the real drug?" to see how effective their blinding was. This one, they might not have done it because it's kind of a phase 2 trial, but maybe they would do that in the future, or I don't know, could the placebo, like, have some sort of nausea-inducing drug in it?
Yeah.
I don't know what that would be, but ugh.
I haven't gone to the results yet, but the demographic of this population was relatively narrow. It doesn't kind of represent my typical alcohol use disorder patient. So they were predominantly white females with moderate alcohol use disorder severity. So this is kind of a very select subgroup, not kind of what we typically see. Not that women can't be affected, but there is a male predominance from most of the other data regarding this condition. Um, In terms of the other critiques, it's a relatively brief duration. Like I said, it's a phase 2 trial. I would think if anything, the longer you treat it, you would probably get more of an effect. I think that looking at long-term effects wasn't really assessed here. This was really kind of more short-term drinking outcomes. The dose was relatively low. Like I said, they're much lower than the doses that we're typically seeing for diabetes, coronary disease, obesity, the OSA doses. So I would like to see what happens as the dose raises further. Um, the exploratory outcome evaluating the effects of semaglutide about the tobacco use, it was a really, really small subgroup. It was only 13 of the 48 patients. So even though there was some findings there, I would really be hesitant to take too much out of that just yet. I mean, like I said, it's exploratory. So it would need its own trial. It's a subgroup analysis of a small population within a small population. So 13 out of 48, I'm not sure if that's enough that I would start getting too out of control with prescribing it for that indication. I appreciate the laboratory alcohol self-administration. I really think that's a cool test because I think it kind of is like almost like a laboratory assessment like you would in a science fair. It really wasn't a patient-centric outcome, right? So like there was no kind of measure of functionality. Kind of, I'd like to see if alcohol use criteria, like if they met less criteria for alcohol use disorder, do they downgrade from the average person being moderate to mild. I would have liked some sort of functional outcome, but again, it's a phase 2 trial. It's not exactly what they were looking for. What do you think, Sonia?
So I think it's a good trial. I think, like you said, it's a little bit exploratory in that it's a narrow population, it's a small group, it's a brief amount of time. It's kind of like proof of concept. So if it shows a benefit, it gives them opportunity to kind of move forward for a bigger trial. Um, but I think it's set up perfectly fine. But yeah, I also agree. Like sometimes finding stuff in the lab doesn't always correlate with how it acts in real life. But they do have some data on how people were doing at home as well in terms of how much alcohol they were drinking. So I think it's good. I'm excited to hear what they found.
So a little bit about the participants, like we said, 48 out of 504 adults screened actually met eligibility. The most common reason for exclusion was that they were actually seeking treatment for alcohol use disorder. So that wasn't that they were, non-treatment seeking. 12 out of 48, that's 27%. So about a quarter were smokers. 42 out of 48, which is about 88%, completed all 9 weeks of the trial. Baseline characteristics, 71% were females, 81% were white. So white females, average age of 39.9. Majority were overweight with a BMI greater than 30, with an average BMI of 32.1. They typically met moderate alcohol use disorder severity with a mean audit score of 13.4. So, like, not to generalize, but basically, this is like a middle aged white female population that you would see in your office. This doesn't kind of correlate with what I often think of as my most common characteristics for patients with alcohol use disorder. The primary outcome was the laboratory self-administration, so it measured pre and post. And it's very interesting that this was statistically significant. So they did what's called a beta coefficient, kind of looking at kind of a relationship with the ratio of the semaglutide to kind of the change in behavior. And it had a statistically significant beta coefficient of negative 0.48 for grams of alcohol consumed, negative 0.46 for peak breath alcohol concentration. And both of those were statistically significant. So the patients that received semaglutide, they drank less and they reached a less intoxication is more of a clinical state, but they reached lower breath alcohol contents. And that was the primary outcome. So it seemed effective in terms of increasing your chances of that. In terms of the secondary outcomes, there was no difference in drinks per calendar day or drinking versus abstinent days. However, in drinks per drinking day, weekly alcohol cravings, and heavy drinking days, there were significant reductions. So those three did meet statistical significance with beta coefficients of negative 0.41, negative 0.39, and 0.84. So basically, very similar to kind of other studies about other medications for alcohol use disorder, that this is really not an abstinence medication here, but it seems to reduce kind of those binge drinking episodes is what you're really targeting here, at least what it came out with. In terms of the exploratory outcome, there was a significant reduction in cigarettes per day in individuals who smoke, beta coefficient of negative 0.1. There was a significant reduction in body weight. That makes sense since this was also a weight loss medication, so negative 5% versus 0.1%, 0.18% gain in the group that received the placebo. But there was no significant effects observed with blood pressure, depression, or hemoglobin A1Cs. And I actually thought that was interesting because I would think that this being like a middle-aged, overweight, or actually a middle-aged obese group of patients, you think that some of these patients would be pre-diabetic or that there would be some sort of statistically significant improvement of A1C, even at a dose that's subtherapeutic for diabetes.
Well, but I don't know if they had it in the demographics. Were there a subset who did have elevated A1C? Was that, like, listed? I don't
I
mean to
didn't
put
kind
you
of
on the
dig into
spot.
that bar. Yeah, you put me on the spot. I don't
Yeah,
have
sorry.
that.
Well, because the reason I ask is that, one of the
It's
reasons
probably
we
in the
love
appendix somewhere.
some giant appendix. Yeah, like, I love these for diabetes because they're non-hypoglycemic, meaning they don't push your blood sugar below normal. They stop it at normal. And so if these people all had normal blood sugar at baseline, it wouldn't necessarily push it any lower. Um, so I'm not so surprised by that unless there were a bunch who did have elevated A1C at baseline. We'll have to, we'll figure that out. Someone can, tell us the answer on social media.
Yeah. So, like I said, that kind of wraps up the results for a relatively small amount of outcomes, but certainly something that I think that we've all been waiting for. The question always becomes like, will these results help me in patient care? So, like, I'm a primary care physician. I prescribe a ton of GLP-1 agonists for primary care. I also practice addiction medicine. Ironically, a lot of my patients in my addiction medicine clinic also ask for these medications, mostly for weight loss. And they desire it very much so. So it's something that I could see coming up very frequently. The overwhelming majority of my patients that drink alcohol in an unsafe manner, they do not want an abstinence approach. They want a way that they can drink in control a little bit better. So the non-treatment seeking part of it does kind of correlate with kind of a use I could see. Um, you know, our current FDA-approved medications really fail to meet the needs of my patients for with alcohol use disorder. And I'm not trying to throw shade here. It's just not the same. Like buprenorphine, methadone, that works incredibly well for opioid use disorder. My patients with alcohol use disorder, I've kind of started the conversation with them about what their goals are. And I can think of, I'll tell them, I'll be like, if you just want medication, I don't think you're going to get the outcome that you want out of this. I think we need to have a more comprehensive plan. And I fail to have a patient where I feel like medication alone is going to get them the desired effect that they want when they tell me what they're looking for. So I think I'm looking for more treatment options in this zone and space. How about you?
No, totally agreed. I mean, I feel like this and some of the other medications for alcohol use disorder, they don't come and, like, slap the drink out of your hand. They just make it easier if you do wanna reduce your drinking or quit drinking, they just make it easier on you. Less cravings, less desire, more, sort of negative effect from the drinking, less positive effect. But yeah, they're not a magic bullet. But I do think they make it easier, and as you said at the beginning, a lot of people just wanna reduce their drinking and reduce the harms from drinking, they don't wanna actually stop altogether. And this would be perfect. It's like you're done after 2, and you just don't want anymore. And that's what a lot of my patients actually want. So I think these are great outcomes.
Yeah, and patients want these medicines, right? So it's a medicine that could help them that they actually want. I will tell you, my biggest axe to grind with these medicines is the cost. That they are unreasonably priced medications, to be quite frank. With an average cost for the semaglutide of $13.50 per month, so $1,350 per month for the pens, which is just either one multi-use pen or the four kind of single injection pens. It just it doesn't it's hard to totally endorse that until the cost comes down. Yeah, I think kind of like a caveat I have about like the cost of care. The average American spends about $11,000 per year on healthcare. Um, you know, 60+% of patients actually of Americans qualify for a GLP-1 agonist with a cost of $20,000 per year. So you're tripling the cost of healthcare on average for 2/3 of the population. It's going to bankrupt the system. So I think that's my biggest drawback of these meds. But I do think it's a very compelling possible option in the future. And I hope the cost drops to
Well,
make it more cost feasible.
I think they will. And honestly, like the list price is not the price that a lot of people pay. I mean, you can get from a compounding doc for 250. I was looking for a patient. You can buy these direct from direct Eli Lilly pharmacy for I think it was 340 a month. I just ordered that for a patient. Um, so it's coming cheaper and this class of meds have been out since 2005 was the first one. Like I've been using these medications for 20 years and they're not even that new and it's ridiculous that they're priced where they're priced.
Yeah, and here's the caveat with that, right? I guess two things. One is so the compounding. If anyone doesn't know this, there's a loophole with the compounding that's going to close at some point. So the only reason that we can compound these currently is because there's a caveat that if a drug is placed on the FDA critical drug shortage list, that you're actually allowed to compound it, and the patent doesn't apply. So that's something that's currently occurring because they can't keep up with supply. Like tirzepatide was able to be compounded up until recently, but it's no longer on the critical drug shortage list. So that window is gonna close at some point.
Yeah, yeah, and hopefully the price will just keep coming down. So I think this is a really exciting article. And I hope the next, the phase 3 trial is coming out.
Yeah.
So, John, we did have some comments from a listener I wanted to share. This is Tom Bernard from VCU Health, friend of the podcast, and he sent us in some very interesting comments about episode 57, where we talked about the What is Recovery study. So I'm just going to read what he wrote, the email he wrote to us. He said, I love the approach of asking the defined to be the definers. Kudos, Toni Morrison. I think there are some real limitations to this article that were a little sneaky that are worth noting. The data itself is almost 15 years old from 2012, and even though the recruitment sites represented a large variety of folks, there was an overwhelmingly 12-step sample, and it was a convenience sample. More than 50% of the participants had attended more than 500 12-step meetings, and almost 85% were abstinent. Treatment and recovery landscape has evolved dramatically since then, so this is more of a what do people with 12-step exposure think, which is still important, but it doesn't necessarily reflect a more diverse sample of experience. I think there's really something notable here, though, that you all mentioned, that as we move away from 12-step facilitated therapy as a dominant treatment modality, which is not necessarily a bad thing, there may be something lost in terms of people's definition of their recovery being about the elements that you all focused on. Finally, I do really like that this article highlights the glaring flaw of the term abstinence-based recovery. This data would suggest that these individuals view their recovery as based in at least 8 things that are more important than abstinence, even though they're mostly abstinent. So thanks, Tom. Keep those comments coming. We really appreciate them. Yeah, and I think this is interesting. He really drives the point home that this is a 12-step focused population. And like we had talked about, it's a lot of people with alcohol use disorder. And I just think there's something different in our kind of modern current era of addiction and recovery. Like just being addicted to illicit fentanyl seems like a different beast than having been addicted to alcohol, or marijuana or Valium or any of these sort of lower dose, lower potency addictive drugs from the past. It seems different somehow. So we do need new recovery data for this new era. Well, thank you everyone for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. I'll put the links in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares. We are produced by Dr. Patrick Beeman and Ars Longa Media. The Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily represent those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.